we have a great lineup for our presentation. Our first speaker is Dr. Ben Danielson. He is an advocate for equitable healthcare and a respected voice on the detrimental impacts of racism on health. He is currently leading a program to tackle youth incarceration by promoting paths to opportunity for young people, especially among youth of color. Dr. Danielson is a physician and clinical professor at the Department of Pediatrics, University of Washington School of Medicine. And for more than 20 years, he worked at Seattle Children's and was the director of the Odessa Brown Children's Clinic, a pediatric care center built to serve the needs of children in Seattle's Central District. Throughout his medical career, Dr. Danielson has been a leader for a more racially just and accessible healthcare system. He is referred to as a quiet hero of health by the Seattle Times. Dr. Danielson once said he wanted to inspire people about the power that they have to be important change agents in the world. And I had a chance to sit down and talk to him, and I can truly say that he is a leader for equitable healthcare and equitable care in our system. Help me in welcoming Dr. Danielson to our conference. Thank you, Dr. Danielson.
Thank you very much, Yvonne and Lori, for kicking this conference off. And I'm just very honored to have a chance to spend time with you all. I'm getting used to feeling close to people even when we're in virtual space and far away. So I just want to thank everyone for organizing and planning this great conference. I know the people behind the scenes do so much work before and during to make this happen, and I just appreciate everybody's efforts. And I'm so glad all of you were able to join today. I'm going to talk a little bit about issues of racism that are pervasive in our healthcare system and some of topics around equity, framing from the perspective of thinking about where sickle cell interacts and intersects with a lot of those topics. I'll probably talk about things that either test what your truths are or push somebody a little bit. And if anything I say is in any way taken as offensive, I really do apologize for that. I just hope I have a chance to share some thoughts, and I hope if it creates a different kind of thinking or makes you kind of curious but not furious, then I'll be really pleased with that result. I'm going to share my screen and go through some images while I'm talking. I find, okay, my voice can be a little boring, so maybe it's easier to go through this and have some beautiful imagery to watch. So if you've heard me talk before, I often use street art and different kinds of murals to sort of convey some of the meaning behind the meaning and some of the things I'm trying to talk about. And I hope at least it's a visual treat for you as we go through this conversation this morning. I'm going to start sharing screen, and I look forward to how you feel about some of the things that come up. It is a pleasure to be part of this space with you all, and I really do look forward to hearing from you if you have the time to share your thoughts or to create dialogue and conversation. I'm going to switch out my share. And I'm starting by just with this image, just telling you how much I honor your brilliance and the sacrifices that you make, the way you contribute your time and your heart and your souls to this important work. I imagine there are many of you who have dedicated careers to supporting the families, the children, the folks who suffer with a disease of sickle cell. And I just honor you for that dedication and that commitment. I hope that you have people around you who recognize all the wonderful things that you do. I hope that in the course of your work, you were lifted up for it. And I also know that if I know anything about you all, like I know about the sickle cell nurses and other professional staff I've worked with, you all kind of know it's also not exactly about us, is it? It's about the families that we serve as well. Conversations like this that bring in a lot of different issues and topics, they're bound to feel like there are a lot of little conflicts in the notes and messages that are shared. And I just want to start with, I'm on this my own journey of understanding issues like equity and racism, and I've really had to come to embrace an idea of both and, that there are different perspectives and ideas that people bring into spaces. There are important things that we need to receive in order to help ourselves grow and help our work grow in the communities that we love grow and thrive. And that means sometimes that we have to hold different ideas at the same time, wrestle with them, and they may seem like they're not in alignment with each other, but it's okay for us to hold them as unaligned ideas until we find ways to bring them together in our own realities. I think you'll see what I mean as we go along. The work in sickle cell is amazing. It creates powerful communities. It creates incredible bodies of work. It has advanced and been on its own journey for a long time, and it's a space that you know better than me, so I'll probably trip up in some of my comments, but I just know that there's a strength that comes with that story of treating and serving the sickle cell communities. There's also an incredible amount of pain, an incredible amount of anguish, an incredible amount of struggle that is also part of that story at the same time, both and. A beautiful story of strength and a beautiful and painful story of hardship and difficulty and people finding their voices within those spaces. Joy and pain, struggle and strength, these are the themes that we live with and that we understand to be part of our spaces. We don't get to choose one or the other all the time because they are both present and they're both part of our realities. I want to especially honor and center the families themselves, the families, the beautiful and amazing people who are part of families that are visited upon by this condition, by this disease. I want to honor and know these incredible families that have done so much to make sure that their loved ones are getting what they need, that have done so much to contribute to our shared knowledge about sickle cell, that have done so much and made so many sacrifices to try to advance the quality of life for the people that they love and we care for. I want to center and make sure that they stay at the center of this conversation at all times, because there's so many factors that swirl around the families themselves, and we just always need to know that they're right at the center. And we also need to know other things as well, because this is what families tell me, that families are not defined by their disease, that the communities that are visited upon by sickle cell disease are not defined by that disease. The people who suffer from sickle cell are not sickle cell people. They are people who also have sickle cell disease. And our understanding of that, our ability to say that to our young people, our ability to own and hold that and see that for all of its complexity. It's one aspect of someone's life. It's a big part of someone's life, and it's still just one aspect of what makes a human, a beautiful child, a brilliant person, just as brilliant as they were. These ideas are really important, not defined just by a disease, not only described by a disease, but known as a full and robust and full human. In a similar way, not just defined by a set of problems. People are not problem lists. The loved ones, the people we care for, those beautiful young people that we serve in sickle cell practices around this country, they are not problem lists. They're not a set of deficits. They're not even a set of social determinants or some other descriptor of a broader set of data. Human people. And more importantly, I firmly believe that if we had asset lists and strength lists in our charts, in our medical charts. Those asset lists, those positives, would outnumber the problem lists and the deficit lists, no matter what disease or condition we're talking about. They would always outnumber the number of problems. And we need to honor that there is strength in that pain. There are assets in the midst of all of those deficits. There are so many more strengths than there are problems that we should be recognizing and honoring and seeing. We also need to know that for the, you know the numbers better than me, maybe 100,000 or more young people and young adults with sickle cell disease in this country, they are not alone. They are not individuals. They're not just by themselves. For those 100,000 people, we have to expand that at least fivefold, maybe to incorporate the families that are part of those individuals who have a diagnosis of sickle cell, and then maybe expand that again by maybe 50-fold to start to name the people who are maybe on the same street, just around the corner from those same families who have a young person or a young adult with sickle cell. And then maybe we have to expand that by 500 more to start to see how the communities and the neighborhoods are impacted by sickle cell disease. And then maybe we need to get to 5,000 more fold to amplify the ways in which whole communities and towns and cities who have young people who are affected by sickle cell disease are understood. And we have to do that again and again. And when we do that, and what the point of that is that we start to recognize that we are all part of this community of sickle cell. We are all impacted by it in one way or another, and we are all responsible. We are all accountable to the lives of those who are impacted by it. Those brilliant young people, the people who love them, the people who know and love and support the people who love them. You know what I mean, man? It just expands. It goes on and on and on in a beautiful way. I also want to talk a little bit more about the way in which sickle cell is understood and known in the spectrum of health and healthcare. I'm going to take a little bit of a step back because there's so many different ways to have conversations about sickle cell disease. Again, I feel a little bit like I know I'm speaking to the experts, the brilliant people in this field who've been thinking and talking about this for all of their careers. It is interesting, isn't it, that there are often different dialogues happening about the same issues, completely different sometimes, pointing in completely different directions, sometimes really speaking very loudly about the ways in which sickle cell is so misunderstood still within our healthcare system, the ways in which sickle cell is so deeply cared for by the cohort of people like you who spend your time supporting the lives of young people and young adults all over this country. There are dialogues and conversations that are going in opposite directions, that are conflictual, that have conflict to them. And I think we have to understand and recognize that, because I think sickle cell disease is a seminal disease in the way we understand healthcare. It is a foundational condition that actually reveals a lot about how we understand healthcare. I'm going to go back a little bit and just share with you that way back when I was in medical school, sickle cell was actually one of the first diseases that was talked about. Now, I'm not gonna lie. That wasn't because there was some super revelatory set of instructors who understood about things like racism and inequity. No, it's just much more biologically based. Sickle cell was a perfect example. If you're just starting to learn about biochemistry, about the structures that make up the parts of tissues in our bodies, about the ways in which our systems and tissues function within our bodies, if you're just starting to learn about those, and you're just starting to learn about things like amino acids, then it's really symbolic and educational to know that there's a disease that all it takes is one switch of one amino acid for another, just one switch out, and suddenly the way hemoglobin works changes completely. Suddenly its propensity to start to create stacks of cells within, of bodies within red blood cells and to go through conformational changes that are hard to undo when stresses happen to our bodies. That connection between one amino acid change and then suddenly red blood cell function change and configuration change, and suddenly the way blood cells and blood vessels function changes, and then the way the blood vessels impact their ability to nourish our organs and other parts of our systems, and how that turns into a whole illness. There's a reason why sickle cell was the first disease that we really learned in medical school. But it was also interesting to me that it kind of stopped at a point of the edge of the body. And there was no education about how sickle cell then impacted families. There was no education about how sickle cell had such a strong social overlay to it, that racism was invited into the space of sickle cell and has remained in that space ever since then. It's been covalently bound to the conversations and the experience of sickle cell disease. It's the opening educational moment for a medical student, and yet it is a closed conversation that doesn't encompass the wholeness of the experience of sickle cell disease. In that way, it really reveals a lot about our understanding of physiology, and maybe, especially in those times, our lack of understanding about the social experience, the issues of inequities, and the issues of racism. In a similar way, I have found, and I wonder if you agree too, that sickle cell disease is maybe the most sensitive test of how our healthcare system integrates and works together. For me, as a primary care pediatrician, connecting to a sickle cell clinic with an amazing sickle cell nurse practitioner, which then connected to inpatient care and ER care and advising on pain medication and management, and the hematologists who maybe work primarily in a hospital setting. Every piece of what should be a smooth, interacting, and integrated set of systems gets tested, gets particularly tested by sickle cell disease, because any piece of that going wrong means pain, means absolute pain, means organ harm, means changes in life arcs and experiences. It is one of the most sensitive tests I would put to you in the way our whole healthcare system works together. And then on top of that, it is one of the most important tests of how our healthcare system understands the other components of wellness that need to be supported, how we need to understand social dynamics, how we need to know what else is happening in someone's life in order to be most ready to support them, how we need to understand the strengths and assets of a family, of a community, in order to be a good, incredible navigator of the healthcare system with families. It is one of the most sensitive tests of how our healthcare system works. And I am embarrassed as a part of the problem, I guess, in healthcare, that often I think that test of our healthcare system has failed historically. Sickle cell is an important test of how our healthcare system integrates, and it has shown us how much that integration has not worked for so many in the past. It's a mirror. It's a mirror not only on how we work together as teams in healthcare, but also how we understand how people's lives are integrated, not only into healthcare, but also into their social and societal experiences. It is a mirror that reveals a lot about who we are as a people. It's a mirror that reveals a lot about how our healthcare system needs to change. And in so many ways, you are the best agents of that change, because you see this most sensitive test, this most revealing experience every day. You understand where things could be better. You have all the best ideas for all the best improvements that could be out there. This is an important thing to understand, the way our lives are experiences of beauty and collaboration and gain, because we're doing things together, and the incredible expression of will and thought that make us part of this human race, part of this space that we're sharing in this moment in time, and part of the same potential for solutions as we are part of the same potential for problems. Both and conflicting ideas, all living at the same time within our spaces. Sickle cell disease does that to you, doesn't it? It makes you see things much more clearly than if you were in one remote corner of the healthcare system alone and didn't see the broader picture. We all have different views and perspectives. We all have different lived experiences. We all see things through our own eyes, interpreted it in our own minds. And yet there are things that we need to have a shared understanding about, that we need to have conversations, difficult conversations about, and continue to have those, because I know they've been happening in many different corners, and yet we have not seen the kinds of changes that I think our communities deserve, that we deserve to be part of, that we owe ourselves and the people that we care about around us. Different perspectives, different understandings, and yet what we need to understand about sickle cell disease and the healthcare system is how deeply rooted it is in chattel slavery and the institutions that promote racism and that create continuing racism in our societies. The kind of racism that spawns also other forms of oppression against other peoples who are marginalized or who are not seen for every amazing, brilliant thing that they have to offer our society. Racism is connected deeply to healthcare. Healthcare is deeply tested by sickle cell disease. Sickle cell disease is a revealer of the way in which racism works in our society. And I use the word racism, and I do not use the word race. I do this intentionally because I've learned from wiser people than me that when we're talking about inequities, when we're talking about differences in health outcomes, when we're talking about the kinds of harms that should not be happening in our system, even when people face great medical and health conditions, it is racism that, and not race, that drives that. It is racism and not race. So we can't necessarily talk about differences in health outcomes based on race. I've had to learn not to say that. Those differences in health outcomes are not really based on race, even when you have a condition or disease that predominantly affects one race, one group of people, like African Americans, and predominantly, but not uniquely, and issues like sickle cell disease. It is racism that causes differences in health outcomes that are avoidable, that we could be doing something about. And it is racism that we should be focusing on and using that word in our conversations. We understand and we watch and we see, even though our intentions are good for making different systems work differently, that for the experience of a young person, for a child coming into an emergency room with pain, for someone who is experiencing a significant change in their health, the way people perceive the melanization of their skin matters. It impacts whether or not adequate pain medication is going to happen. It impacts whether or not people are going to see and have compassion and empathy in the way that we consciously need to for everyone. It's not conscious often, but it is often present. It is almost always present as part of our healthcare system. Our different treatment of people based on racism that is driven by our perceptions of people based sometimes on just how they look to them. We understand how this feeds and seeds our healthcare system. It's important just to know that what we have is something that is long infested, long been an illness in our healthcare system. And one small example is just the ways in which we document and record how our own healthcare records reveal the ways in which we make assumptions about people because of racism. Our own electronic health records been shown again and again to be replete with different kinds of comments, different kinds of innuendo, different kinds of notations, different kinds of messages about whether or not we believe somebody if they're Black compared to whether or not we believe what somebody is telling us if they're white, whether or not we think that their story is credible to us in our healthcare system. And I say all of us because this data is so comprehensive that it is hard for anyone to say, oh, I'm not part of that system, because we all are part of that system. Our biased documentation, the biased storyline that will be read by the next nurse and the next doctor and the next nurse practitioner and the next person caring for this person. We create a storyline that lives on in our records and that is interwoven with bias. These issues are important to understand because they pervade the experience of families, as you know, who interact with our healthcare system. There's a different kind of scrutiny, a different kind of being watched, a different kind of being judged, a different kind of being well, surveyed by our healthcare system. Any family you know will tell you coming through the doors and into our hospitals is a different experience if you're Black, is an experience of knowing that you're watched more closely, that if you yell too loud, that it's considered a security violation. If you are too quiet and not emotional enough, it may be considered a CPS referral because you're not caring enough. The number and amount of scrutiny that the families have to face entering our systems, let alone the care issues and everything else, but just the environment of care is significantly different for Black and brown families especially, and other families as they enter our healthcare system. We have to understand that and wrestle with that and seek ways to make sure that we are making differences and changes. This is important. And this slide is especially important because I was told by the Ohio Nurses Association credentialing that you will not get CNE credits unless there's at least one graph in my presentation. So this is my one graph for you all, just to make it official so you get your cred. And this is about how the issues of racism and oppression affect every part of the lives of people who come to our care facilities for treatment of sickle cell disease, for any other care. That there are lives that are intentionally kept in poverty. These two lines are so demonstrative to me about the change in household wealth for white families as an example versus Black families as an example in this country, and how flat that line has stayed for Black families. And you can go back another 50, 100 years and that line stays flat, near zero. That means the extra money you might need for a car repair, the chance to send your young person to college, the opportunity to pass on financial wealth or a home to someone else is severely limited in this country if you are Black. And it is not by accident. It is not by some just random set of motions that that line stays low. It is by intention, by systematic oppression that happens in this country, sometimes through the most conflagrational acts of violence in communities, Black communities that have been thriving. Sometimes it is by the more incremental, the more subtle, the more unspoken and unseen, but irrefutable acts of socioeconomic oppression that happen to Black communities in this country. The point is, no one comes into a healthcare system without being part of these other systems and these other experiences that are part of their lives. That the overlap between oppression, between racism, and other parts of struggle in this world are significant and real, and they ride side by side. The issues that create a sense of emergency about our climate change are affecting our low-income and our Black and brown communities in this country to an extent much greater than other communities. The impact of environmental change on the shoulders, on the hearts, in the lungs, in the blood cells of our Black and brown communities is part of this amplified effect of oppression and racism on the communities that we are trying our best to treat with one of the most severe illnesses that is the most sensitive to toxic exposure that we can think of. These issues pervade the experiences of the families that come to us for care. And they make each step that makes it harder for families to be fully seen and heard and recognized in this country affects their ability to be well, and their ability to be well affects their ability to be participating members of our society. As we decrease opportunities for true voting representation across our country, we decrease the possibility for our families to speak for themselves, to be seen and heard, to advocate for their needs across a host of issues, including within our healthcare system. As we try to curtail and truncate the educational opportunities and exposures for our young Black and brown children, they are not seen. They're not seen like they would be seen if we made sure that our bookshelves and our schools and across our libraries were replete with every image that someone can see themselves in. They have the stories that contain all the stories that are part of our legacy, good and bad, as we grow and learn and become better as a society. We need to know and understand our stories need to see our histories. We need to see ourselves in those stories and histories. It is not possible for us to make change without this kind of expressive understanding and visibility. As we change and truncate the rights of women to make decisions about their health, we change the possibility of women leading families, making decisions for their own well-being, to be fully able to participate and to be fully able to see their rights in our healthcare systems. All of these things are interlinked and they're interspersed. Sometimes over the past 3 or 4 years especially, we started to make efforts to try to improve the way our healthcare system relates to communities and how it promotes equity. We've seen some ways in which equity officer has been a really common new job description. We've seen different ways in where DEI and other parts have been worked into our healthcare systems, and I would say that they're not always done with great success. There are times when it is just used as an expediency. What I mean by that there are sometimes that's just using the language of equity, appropriating it, taking it, borrowing it from the real struggle, I'll say, and just using it to try to say that you're doing something when you aren't. Just appropriating language doesn't mean that you're actually promoting change. There's the pitting of equity, that sometimes there are systems, hospitals, and different kinds of systems, educational and otherwise, where there's actually an instigated pitting between one group of oppressed people and another group of oppressed people. Because as long as we fight within and among other oppressed people, we won't be fighting as effectively for change. There's a delaying of equity and sometimes measuring in micro nanometers change and calling it significant when it really is not the kind of change that we need to see. And there are the reins of equity that sometimes say that if you have a job that says DEI in your title, you are still working for the same power that you're trying to change. And that same power may be working very hard to make sure that you aren't able to do the change that you want to see. These are the things that we're up against these days, even as we try to start to see change happen. These are the factors that we express and that we face and that we have to be aware of as we move forward, because these are the headwinds, these are the challenges, and these are the things that sometimes make people want to rush to closure on topics that are really important. Makes people want to paint over the issues that just 2 and 3 years ago were some of the biggest and most important issues our society was talking about. Make us want to hurry and run back to the way things were, when what we don't often acknowledge is the way things were. We're harming a lot of communities, especially the same communities that are visited disproportionately by diseases like sickle cell. This rushing to paint it over, to cover it over, to change, to revert, to forget, to allow time enough to pass so that we don't have to pay attention to this issue. This is one of the amnestic diseases of American society that I think we need to be much more cognizant of and less tolerant towards. These are issues that we have to face because a truth for me has been that as I've worked through healthcare systems and other systems, I used to think that there were a bunch of us that we could come in there and we could make some changes, we could tweak the cogs, we could oil a space here, we could improve something there, and that would lead to the kind of fundamental change that we needed to see. I was seeing our systems as broken and needing fixing, and it's taken me a while at least to realize that these systems are actually working exactly as they are designed, that they are getting exactly the outcomes, the racist and oppressive outcomes that they were designed to get. And so for me, the kinds of solutions that we need to be thinking about, they're not tweaks, they're not small fixes, they're not about repairing broken systems. They're about actually understanding that those systems are doing exactly what they're designed to do and responding as if that is where we're coming from in our understanding of it. These are hard issues. We're talking about these things. These are hard issues to come to grips with because I don't know about y'all, but like life is like fast and busy, even as we navigate through times of peri-COVID and even as we reoriented ourselves to home time versus in-person time, virtual versus meeting together, all of these things, we have maintained a kind of hectic pace that is exhausting for one, that is overwhelming and disempowering in your own sense of your own control over what you do and when you do it. And maybe more importantly, it actually makes it hard for us to step back, to pause, to breathe, to actually look at things and say, wait a minute, do we need to be doing things that way? Wait a minute, is that the outcome that we want to see, that we expect to see? Are we satisfied with where all this hustle and flow is going? Or should we be actually trying to figure out if we're going in the right direction rather than just keeping running as fast as we can without a sense of where we're going? These are the things that we need to start to find ways to wrestle with and understand. And we need to start shifting our thinking away from, oh, well, I can't do anything about that, or those are problems that are outside of my lane. We need to start getting a little more Angela Davis into our hearts, I think, and rather than accepting the things that somebody tells us we cannot change, we have to change the things that we cannot accept. This is our call to ourselves. This is our inner reflection that we need to find and search out and live into and grow within our own souls, our own hearts, our own heads, and make them part of our own actions. This is a place where we find, for me, I think, the seeds and the beginnings of a hope for change that has eluded us and has not been part of our reality for much too long, for generations, for centuries. The seeds of hope come, I think, in stopping from saying that we have no power. The seeds of hope come, I think, from stopping the idea that it is up to somebody else. The seeds of hope for me come from actually understanding that the things that somebody tells me I'm not supposed to or able to change are the very things that might most be in need of my actions, our actions, to make change occur. Hope is real. Hope is alive in the spaces where sometimes the greatest pain and agony and angst can live. Hope is right there. It's not a thing you wait for, I will say that, but it is something that you decide for and that you live for, and from that you act and you become part of the agent of change based on that hope. Hope is there, and it's in understanding the inherency of people around us, that there's not a need for somebody to prove themselves worthy of the best possible healthcare you can have in this country, in my view. There's not a need for someone to prove that they are worthy of our best care, that there is inherency. And what I mean by that everyone for who they are, they don't have to be a superstar, they don't have to be somebody who has outperformed everyone else in some particular way. Who they are, who you are, is absolutely enough. You are enough. I wonder what it looks like to have conversations even within our workspaces about you are enough. And what could we be doing because we know we're enough, not because we're going to be asked to do something superhuman, work extra hours, or do something beyond the scope of what we think is our job description, but because we are enough. It actually means that we have enough in order to be able to do some pretty incredible things that we've talked ourselves out of in the past. Just my opinion. I would love to hear somebody push back on this, because I'm all bought into this idea, and I want to hear your thoughts about that too. We are part of really powerful and beautiful communities. We are part of spaces and places that have so much to offer the rest of the world, different ways of thinking about things, different ways of solving problems, different ways of getting to spaces that need to be gotten to, that are just not even accepted or allowed into the conversation of the traditional ways of doing things. We are part of communities that are powerful and beautiful, that the messages and the work that was happening 1 and 2 and 3 generations ago is sadly the work that needs to happen today in some ways. But I'm also so hopeful because I saw the power that came out of that time, and I know that we have the same kind of power that we could be using today. We are communities that are beautiful and powerful and amazing, and they make up this rich panoply, this rich range of people who choose to go into the serving practice of trying to help families who suffer with diseases like sickle cell disease, who choose to show up when people are at their worst and want to make the best possible thing happen out of that time, who choose to see the best of potential and possibility and assets and strengths in people, not just the misery or the deficits or the hard things that they face. That gives me hope. That gives me an incredible amount of hope in the space of this. Hope that, as I've seen over the course of my career, the beginning of the lifting of masks that we have all had to wear. And you know what I'm talking about code shifting, about wearing a particular face, about hiding some of who you are in order to navigate a healthcare system that hasn't historically seen you for all of your beauty and strength and abilities and passions. We need a healthcare system that sees all of you, because all of you bring so much more than just the mask that you wore. We need this, and I have hope that we can see this, because we are growing and continuing to see ourselves as we work and move forward in this career. We've been in this space on some level, in some way, I think you'd all agree, for us to understand each other better, for us to show up in people's lives in a way that says, my life is not yours, but I want to see you and listen to you and understand you. And through that understanding, I think we're both going to grow and get better. I have some things to offer, and you have so many things to offer me as well, that this is a collaborative practice, not a one-way directional care scenario, and that we have things to share, to actually see through someone else's eyes, to understand someone else's experiences, even at a small level. That is an amazing human thing, and it is part of the space that you're in, with such great possibility to be part of that. It takes work, it takes planning, it takes actual organized approach, because the machines are kind of working exactly the way they're designed. So we can't wait on something else to help make change happen, for that hope to manifest in the way that we want it to. We got to plot, and we got to plan, we got to strategize, we got to organize, we got to mobilize, we got to do the work that we need to do to make sure that we are part of this potential, part of this change that I think no one would refute that we need to see in healthcare and in the societies around us. We need to be lifting up the voices of those most impacted by the conditions that we're trying to help and support. Every space and every place that all of you all, any of you all, are lifting up the voices of youth in this space is powerful. It's powerful, and it is part of the seeds of hope and change that we need to see. And those voices need to be amplified even more powerfully. You need to share how you are making youth voice present in your space with other people who have not been successful in that yet. You need to share how you've been going over the ups and downs of trying to make that happen, so that someone else who's struggling with that doesn't feel like they're all alone in trying to make that happen. This is work for all of us. And it's time for us to be thinking a little bit differently. I'm trying to think a little bit differently about anti-racist work and work to promote equity. I spent way too long first, like trying to show data about why proving that racism affects health and health outcomes. I'm done with that. I'm not going to do that anymore. Second is understanding we're talking about racism, not race, like I mentioned before. Third, maybe, is understanding that these systems are working the way they're planned to work and not broken. And fourth is this thing I'm trying to kind of grapple with, which is that we have to stop talking about gaps. That every bit of our language around equity has been often built so strongly on the idea of gaps. What I mean by that is we talk about disparities. We talk about disproportionality. We talk about differences in outcomes that compare to what they could be for a different group of people. That I can't negate the value of some of that thinking. And I also think if we only stay in that space, we will never get to where we need to be going. We will never challenge ourselves enough to see the kind of society we want to see. If we only say that the infant mortality rate for Blacks compared to whites is this far apart, and the goal has to be for them to be the same, I think that is ultimately not the journey we need to be on. It's not okay to say our work is done, like, good, we did our work, perhaps by making everybody's infant mortality terrible to the same extent. That's not okay. It's not okay to say that the white privileged world standard is the gold standard for everybody, because I don't know, I see so much promise and difference in possibilities in so many different people. I think if you only ask them to get to some standard that is comparative to some other group of people, you will never know what we're truly capable of. There's a brilliance that is different than the potential brilliance we've seen to date in maybe our best performing kind of health outcome populations. There's a difference in potential that each of us holds. And as long as we are held to one standard, one white standard, we're kind of still centering the same kind of, I think, racist perspectives that have gotten us to this place in the first place. I'm thinking about that. You can tell I'm not even using the right words yet, but we have to get past this talk of narrowing gaps, because narrowing gaps is not enough. We have to get past this talk of our work will be done when the differences in health outcomes are no longer present based on racism, because that's not the end of the work. It does not honor the potential that each of us has to thrive and show something completely new that nobody else thought of before, to do something that's incredible, that busts the whole chart all off of the table, that makes it possible for us to evolve and transform in a way that is mind-blowing, it's amazing, rather than for us to revert to some kind of mediocre norm in order to see how things are going to go. Let's face it, our healthcare system actually does pretty poorly for the most privileged in our society to begin with. We have health outcomes for many of our richest and most privileged people in this country that is still way worse than the health outcomes for many, many other countries. We should not aspire to be just as worse as the rest of the worst parts of this country are. That's not acceptable. How do we stop talking about gap talk as we talk about racial justice, anti-racism, and promoting equity? Equity is not equality. So these gap issues are more about equality than they are about equity. What's the next conversation that we need to be having? There are ways for us to be activating and working on our day-to-days around issues of equity and racism right now. I made up this kind of thing based on the ways in which I've watched surgeons improve safety and outcomes in their operations. They often have a surgery timeout right before they do their operations, where they pause, look at a checklist, make sure they have everything they need, look at the people around them, make sure they have all the right people ready to go, make sure they have the right patient in the right place that they're going to operate. Those basic steps have made a big change in operative outcomes over the last 20 years. And I actually have this feeling that it's just the pause itself that carries a great amount of value. You could fill it in with any number of steps that you want to, but pausing, taking a little moment to pause and breathe and contemplate what you're doing, I think it changes the way you do things that are really important. So maybe there's space for like an equity timeout. When you're about in a meeting to make an important decision and you have the chance to pause and consider, what are we not thinking about? Are there voices that are most impacted that need to be amplified? Are we making assumptions that we need to understand better? Who's going to benefit the most from this? And is that who we want to benefit? Will this actually help us make improvements? Look at me there, I even have leftover language about gaps in there. You might have other kinds of things that you would care about. What's important though is that we see that we have a chance to think differently just by sometimes breathing, sometimes pausing, and trying to understand the consequences of our actions. It could be a minor thing, a nursing meeting. It could be a minor thing about scheduling. It could be a small thing about whether or not to introduce a language diversity into our work, or it could be a major decision that a hospital or organization is taking on. There are other ways, I think, in which we could improve the work that we do. And I'm really a fan of focused universalism that says that when you take the time to actually try to make sure your work works best for those most impacted, that everybody benefits from that. Everybody benefits. In a way, it's the opposite of a rising tide. Focusing on those most impacted actually makes it better for everybody else. These are issues that really help lift us up, that help move us forward, help us understand how we work better with each other. And I am convinced by this very controversial statement that it is easier to lift people up than it is to hold them down. Oppression is hard work. It's part of why we're exhausted. Oppression is harder work than lifting people up. This is the work for all of us that we need to be doing for each other, for ourselves, and for a future that we care about. This is the work ultimately of finding our space to create dignity. I'm going to pause there and say thank you for your attention. I'm so honored to be here.
So thank you so much. And all I can say is, wow, just wow. This has been amazing, and all of the comments are just phenomenal and fantastic. So I think I want to change up a little bit. We have quite a few people on, but I really would like to have a little bit of a conversation. So if you want to ask a question or say something, raise your hand, and we'll try to see if we can get to you and unmute your mic. And so, Dr. Danielson, come back. Have you gone off your camera? So could you unmute Coretta, please? Dr. Jenneret?
Yes, I'm unmuted.
Okay. You have a question?
Yes, I agree with everyone. What an amazing presentation. My question for Dr. Danielson would be, how do you practice self-care while engaging in this important work? And I ask this question as a sickle cell advocate and as one of the DEI officers in an academic setting and a PhD prepared nurse.
Woo.
Sorry, not sorry.
I honor you. Yeah, I don't even know what your business card looks like, but it must be one of those things that folds out telescopically, because that's a lot of work and a lot of accomplishment. So congratulations on that. I think we all have different answers that we would have to this issue of self-care. I think one of the most important first steps, just to be honest with you, is knowing that we deserve it. I would guess, I wish I could have people raise their hands, but raise your hand out there if you have felt at times like the suffering you see around you means that your suffering doesn't mean as much, or the things that people need from you means that you don't get to take the breaks that you wish you could. Maybe the people that you support are so important to you that you would sacrifice yourself for them, even though somebody might tell you and you might nod when they said to you that you can only be good to them if you're good to yourself, that you can only be serving their needs if you actually have yourself as your whole full self. Giving yourself permission is absolutely the first step. And I'm just going to say we're all bad at that in health. We're just bad at it. We can give good advice, but I'm not sure that we actually, and it's just permission. It's really understanding like that I'm worthy just the way I am, that I could put in another 12-hour day after day after day, 7 days a week. And there's also like a beautiful world out there that I bring something better back to my work because I slept well, because I breathed, because I took a little time out, because I spent time with somebody who loved me, who did not want to talk about hemoglobins. This is important. And I think that's step one that everybody needs to think about. You all are brilliant. You have solutions. You know where your love is coming from inside and from the people around you. And it's a matter sometimes of just making sure that you create the time to do that. Our systems make that very hard, make you feel guilty sometimes. And I think that's a shame. That's a problem. I think that as we move through our work, we create opportunities sometimes to lift up that kind of better time off and other things for each other. I also think our workspaces are better when we have time to just share, debrief, I don't know, let the wind out, spill the tea, whatever you want to call it, having a chance to spend time with other people in the same struggle and to share how you're feeling. That is an important part of also breathing and being able to do your work better. You are all brilliant. You all have nothing to prove to me, and you've been doing great work for a long time. I know our workforces are challenged and stressed and things like that, um, but we need you to stay. We need you to be there, and you can't be there if you're not being good to yourself. I don't know if that was helpful or not, but I really appreciate your question.
Thank
Very
you.
helpful. Thank you so much.
So we had a question. What was the name of the last theory you mentioned where the work meets the needs of those most impacted?
Oh, thank you for that question. I call it focused universalism. Um, I, y'all gonna laugh at me, but I've in my life tried not to use violence and military words when they're not necessary. Just like I wish our safety services didn't use violence when they didn't need to. Like I wish our police didn't use violence when they didn't need to. So I think the original term might have been targeted universalism. I don't feel like being targeted, so I use focused universalism. The best example, which is pretty kind of obvious, is the curb cutout for someone who uses an alternate means of moving around and other than walking. That curb cutout that allows someone to get across the street, say if they're in a wheelchair or something, is important. It's designed. It was created specifically for the needs of people with different abilities to get around. But lo and behold, when you do that, all of a sudden, the auntie I love, who's just not quite as stable on her feet, she gets across the street more safely. The mom over there with that stroller, she gets that stroller across the street more safely. The uncle or the granddad who's got a cane and a little bit slower getting across, he gets across the street more safely. And even me, who grew up in Washington, D.C. and learned how to cross the street anywhere but corners, might actually start to cross the street at the corner at a curve out. In other words, this curb cut, which was designed for someone with a different ability in a wheelchair, say, is suddenly beneficial to everybody around them. That's an example to me of focused universalism.
That's fantastic. So I actually shortened your introduction because I wanted to get right to your talk because you're so phenomenal. But just want to give a little background. Dr. Danielson, as I said, worked for 20 years at Seattle's Children with Odessa Brown Clinic, and he quit, and which I can only imagine was a very nice, lucrative position, and he quit his position, citing racism. And one of the things that you've said was it wasn't just one thing, but a lot of little things. Could you just talk a little bit about that?
Yeah. Painful. So sorry if I struggled through this, but important. That it was the best job I will ever have. And maybe it wasn't so much about the pay as it was about the people who got to work beside. I'll bet some of you know what I mean. All of you probably do. And the community, this beloved community that like allowed me to be part of their midst as a primary care pediatrician for 20 years or so. The honor of that role is just most amazing. Sometimes there are things that come along with roles like that that become too much over time. I watched too much harm happen to that same community that is beloved to me. I watched the way in which the hospital that I worked for had security practices that targeted Black and Brown people specifically, and were part of the same kind of policing that we see across our society. I watched different treatment in ERs, such that, again, tell me if you all don't do this too, but I found myself going to the hospital with a lot of my patients to the ERs to make sure that they were listened to and heard, and to try to be at least a one more voice kind of to help other people hear their voices. I found that the way in which the hospital I worked for addressed issues of racism was so inauthentic, so un, um, unreal, unrealistic, and not really centering the communities. that harm was cumulative. I faced my own issues within the hospital. What was more important was watching again and again. And like a lot of you, I spent a lot of trying to work from within, and finding often that those efforts were just undermined or pulled apart, or created more of a sense of feeling like the hospital was kind of coming after people like me. So I found that perhaps my voice would be stronger outside rather than inside. And I've learned a few things about this too, that I honor everybody who's working within systems to make change. You're doing such important work, and maybe it's even more important for you to take care of yourselves. I honor people who are also working outside of systems and who are pounding against those walls for change. And I think that between us, we are pretty powerful. I know that there are changes that are more meaningful that will happen here in Seattle and in other parts of the country because of folks like you, and because they don't even know what we can do, how powerful we are when we get together. They don't even know just how many gifts and talents and brilliance we have in each of us. And when we pull those together, I'm just saying, this world's going to be a better place, because I'm going to work with anybody who wants to work with me to make sure that equity is the shining star that we get to.
Fantastic. Pat Corley, you had your hand raised. Can we unmute her?
I did have my hand raised, Yvonne. Dr. Danielson, I'm overwhelmed. I am full. I've been in the sickle cell arena, with my family of people living with sickle cell disease for a very, very long time.
Mm-hmm.
And I don't think I've ever heard a physician share the reality of the walk in the sickle cell community. And I think if I'd heard this discussion from you 30 years ago, I probably would be retired right now and not having to do the work that I find myself doing on a regular basis. Like yesterday, advocating for somebody at a hospital that an unsuccessful effort to change how they were treating someone with sickle cell disease, which I see so commonly, in our community. And I just want to thank you for all of the sharing that you did. I think I have a pretty good skill set, but I think you made my skill set better.
Oh.
And you also made me feel like there is hope, that if you as a physician, as a person who's been in higher places, still have compassion and care for people with sickle cell disease, that perhaps if we look at things, if we add to our tool chest, perhaps we can do this differently, and we can do it in a way that will affect change for people living with sickle cell disease, and will make people with sickle cell disease not give up on life, be hopeful, and go forward, and be able to live their normal life. So I just thank you so much for your talk. And Yvonne, I thank you for recruiting him to do this talk, because I don't
I'll just
know.
tell you, when I met him, that's the first thing I said to him when we talked. I was going to get him to talk.
She's been telling me about you since she met you, and how amazing you are, and you know what? I'm in your fan club.
Oh, stop.
And I thank you so much for what you give to this community. And I know the clinic that you worked in. I was actually at University of Southern California, sickle cell program. I worked with an amazing doctor too, but he just, he wasn't in the same realm as you are, And so thank you again for all you're giving us, and the new tools that we can add to our tool chest, and the hope. That's the biggest tool you've given us, is hope that we can make a difference. So thank you.
I hope
So
I can tell you're already making difference, and you could see I shortened the talk a little bit because I really wanted to hear from you all. So that was a gift. I'm so grateful to you, Pat. I feel like I love you like a sister already. So I feel like my community just got bigger just by hearing your voice, and it makes me so grateful to Yvonne for this invitation again.
Thank you. We have a couple more questions, and then we'll let you go. Do you have any recommendations to give for curriculum bias training for medical professionals treating people with sickle cell disease?
I get a little nervous sometimes about nicely, tightly packaged trainings because, well, I think I don't need to say too much more about that. Other people might have different kinds of opinions. I often feel like there's no substitute for bringing young people with their own experiences around sickle cell into spaces of learning, and both sharing the kinds of things that would inspire a young healthcare person to keep going in their career, and also some of the important lessons that need to be learned. I also feel like there is some basic truth about the more of us, the better. The more times that young people see somebody looking like them, like you all, so many of you represent so much to the people that you care for because they feel like they can say something to you that they might not be able to say in other spaces. And the more that we continue to expand that kind of representation, the better, the better, the better, especially for diseases like sickle cell, I believe. I also think that there would be ways in which education would sometimes want to shortchange this and create like one class. I don't know, again, raise your hand if you've been invited to do that one lecture, that one talk at that one school. And to say that stands up for 400 to 600 years of oppression is just a little bit of a hard bit of math for me to fully pull together. So it can't be one class, can't be one book, it can't be one conversation. It really has to be as systemic a conversation as it is systemic a problem. I think I'll pause there.
Thank you. And we'll take our last question. This is from a student, and I'm going to address this also.
Okay.
As a student who is currently training as a genetic counselor, but is questioning going into hematology because of this conversation, would you have any advice for me? And I'll just say that you are needed. There are not genetic counselors. You can probably count on your hands the number of people who are dedicated hematology genetic counselors. That's one of the biggest things that we have that we're in need of, because as you know, it's a genetic disorder. So we need you. So now I'll let Dr. Danielson address it.
I'm just going to echo that. I also saw that in the chat. We need you. We absolutely need you. I think whenever I feel something that I'm anxious about, or even ambivalent, or even negative about, I do my best to shift into a space of curiosity. I try to understand why I feel reluctant, nervous, or uneasy about something. And I explore that, because sometimes I reveal something really different. It might reveal to you, I won't speak for you, I don't know your life, but it might reveal to you just how much more important it is that you do go into that space, you do go into that field, and you do contribute every bit of your heart and soul as much as you can, and take care of yourself to that work. So I honor curiosity and a deep exploration and self-reflection. Everything that I say, I really hope is taken from a place of hope, because I feel so good, especially if I know someone like you is going into a field like this. I feel so good about the future. I feel so great about the potential for us to build a better world for all of those communities that we love so much. And so I'm gonna have faith in you to do your self-reflection. Think hard and in your heart, but I will bet that you're not a person who's walked away from challenge just because it was a challenge. And I'll bet you're somebody who stepped into a space because you knew you were brilliant, you had something to offer, and because your heart kind of told you to go in that direction. And if those are things that are true, I would ask you to keep on that path for in as many ways as you can. I'm sure there's lots of ways to be given back to your community, but boy, genetic counselor would be a really great one.
So thank you again, Dr. Danielson. They're not words to express. You gave everyone a very uplifting presentation, but in our hearts, you also uplifted us. So thank you again.